Hi, I'm Dr. Robert Eckel. I'm at the University of Colorado Anschutz Medical Campus in Aurora, Colorado, and my position is in the Division of Endocrinology, Metabolism, and Diabetes, and in the Division of Cardiology. And I'm going to turn it to the other members of this panel to introduce themselves. Dan?
Hi, my name's Dan Bestison. I'm an endocrinologist at the University of Colorado in Denver.
Sangeeta?
I'm Sangeeta Kashyap. I'm professor of medicine at Cleveland Clinic, Lerner College of Medicine, and I'm an endocrinologist by training.
Ninh Nguyen. I am a bariatric surgeon from the University of California, Irvine.
All right, our topic today is this kind of evolving paradigm of the approach to the treatment of type 2 diabetes. I mean, historically, bariatric surgery, now called metabolic surgery, right, Nin? We're calling this metabolic surgery because it's no longer just bariatrics we're concerned about. We're going far beyond weight. This is a procedure now being applied to the treatment of type 2 diabetes. And the question that comes up, how low can the BMI really go in terms of being an acceptable approach to the treatment of type 2 diabetes? Let me start with the internist, and I'll come back to the surgeon in a moment. Dan, what are your thoughts about this? A BMI as low as 30 to treat type 2 diabetes with a metabolic surgical approach?
Yeah, this has been controversial, but I think as more and more randomized control data has come out on treating people with type 2 diabetes with metabolic surgery, it seems that the benefits are there for people with lower BMI. In Europe, I think already we're looking at people with a BMI of 30. And will it ever go below that? I don't know. But I think what we really need is that foundation of randomized data. But the guidelines in the US here still are 35, but I think we're moving lower.
So, Gita, what are your thoughts here? And if you're going to approach a patient with a BMI of 32, can we get the procedure reimbursed so Nin gets paid from the procedure?
Well, at least in some insurance plans, for instance, in our employee health plan, if you're under the care of an endocrinologist and you have documented comorbidities and your diabetes is considered refractory, so if you're on multiple agents not achieving glycemic and other therapeutic targets, then it's indicated to refer to bariatric surgery, and yes, there is compensation. Of course, the banding procedure, which we don't really consider as a metabolic procedure, but does facilitate weight loss, is approved, for patients with BMI over 30. So that's something that I'll always consider.
And what do you tell your patients when you introduce this as an option for therapy in terms of the benefit versus continuing on diabetes medications, the multiple ones we add on to try to achieve glycemic control?
Right. So, initially the conversation was about diabetes remission, where you were able to achieve normal blood sugar control without the need for any medications. But I think for patients, the more important message is that they can expect to be on less medications, especially in most of our clinical trials. They can get off of insulin, and so to me that's a huge boost in quality of life, compliance issues, and if you don't have to take multiple injections of insulin and yet still achieve a appropriate therapeutic target for glycemic control, this is what patients want. So to me, this is one way to introduce surgery to our diabetic patients.
So then as the patient approaches you for their visit, and by the way, I think us endocrinologists, internists who refer patients to you, tell them that the referral to a surgeon, a GI or metabolic surgeon, is one just for their opinion as to their operability. So then when you see a patient for the first time, what kinds of assessments do you make before you consider them a surgical candidate, and what are your promises to them in terms of the benefit of the operation to take care of their diabetes?
Well, certainly we work in conjunction with the endocrinologist to evaluate their diabetes. And, it's not just the presence of diabetes, it's really the patient that has difficulty in controlling their diabetes. So we communicate with the endocrinologist, regarding that aspect of it. So certainly a patient with hemoglobin A1C greater than 8, patient on multiple medication, patient requiring injections, and patient who has long-standing diabetes. These are the one that actually truly needs it. Going back to your point with regarding to the hurdle for insurance coverage, we definitely have that hurdle. And it's not just BMI group less than 35. We have the hurdles, even patient in existing that qualify for bariatric surgery, including BMI 40 with diabetes, we still having that hurdle. A lot of the hurdles, essentially some insurance will not pay for it completely. and some insurance, will provide certain hurdles for the patient to jump through before you even get bariatric surgery. So before we even try to, change their criteria to get patient below 35 to get access to surgery, I think we have to do a better job in terms of get access for the patient who actually needs it right now.
Now let me challenge you on one point you made, and this is an area that I'm less convinced about. You said the patient with long-standing type 2 diabetes. My impression of the literature is the patient who is earlier in terms of their surgical approach is likely to do better because the islet, the beta cell, continues to function a little bit better. What are your thoughts about that?
No, I totally agree with that, particularly for the patient with greater than 30 BMI. But what we don't know about that is really the patient less than 35 BMI. So patient was 35, I think there's a lot of data to substantiate that, yes, the earlier you intervene, the better, and the better chances for remission. The data regarding, for BMI less than 35 is unclear at this time.
Okay, so we think medically about patients we refer to surgery all the time in terms of relative risk. In other words, the benefits versus the risk. Dan, what kind of conversation do you have with your patients to assess whether or not they're a safe surgical candidate?
Well, certainly I think our job as a referring physician is to try to optimize the patient's medical status before surgery. It's an elective surgery, and so to make sure people have evaluation for common comorbidities, things like sleep apnea, making sure if they have heart failure, that's well controlled, make sure they're getting CPAP if they have obstructive sleep apnea. And then nutritional preoperative evaluation I think is really important too. Vitamin deficiencies following these procedures are common, but a lot of these people go into surgery with vitamin deficiency. So I think making sure the vitamin status is optimized preoperatively. And I think the other important thing is in women of reproductive age, really having that conversation about reproduction.
Dr. Kashyap, another thing that comes up often is if you look at the SOS data, which was not a randomized controlled trial, and the Cleveland Clinic has done one of the finest randomized controlled trials, the blood pressure and LDL cholesterol effects were not permanent. Many people returned to baseline.
Correct.
So what can we promise our patients? And I have an opinion before you answer. It's this. If you've got long-standing hypertension, it may not be cured by surgery, even though during active weight reduction, the blood pressure comes down.
I think, with lipids, with blood pressure, we see less of an effect of surgery, but I think it's because most patients are so medicated and they're so controlled. Most of our diabetic patients, they're all on statins and they're on ACEs, ARBs. We might require less medication, so we can at least tell them you'll be on less medications. But again, if it's long-standing, it's very unlikely that you're going to see them return to a normal level. And that's the same thing with diabetes. These are all chronic conditions. We expect to see a huge improvement, but some of these, comorbidities are genetic in nature and family history, et cetera. So there are other factors that play into this, the way we evaluate them.
And then we're at the Cardiometabolic Health Congress, and this Congress has evolved over the last decade plus about that overlapping Venn diagram between metabolic diseases and cardiovascular disease. I mean, the cardiologists tell us routinely that many people in their coronary care units have glucose intolerance if they're not already diagnosed. What, in fact, do you think about when you discuss surgery with your patients who already have cardiovascular disease? Is that a concern you have surgically, and how do you evaluate these patients?
Sure. We work with not only our endocrinologists, but also our cardiologists to evaluate these patients. Certainly, the patient undergoes extensive workup prior to the surgery, make sure that their cardiac status is optimized even prior to the surgery. I think it's also important to discuss with the patient the selection of the procedure. There are multiple procedures that's available in terms of bariatric surgery. Just to go back to your point about the SOS study, that procedure that was done primarily in SOS study is called the gastroplasty, which essentially is an obsolete operation. We don't do that operation anymore. And the reason for that is that it has long-term side effect with regard to obstruction, regurgitation, reflux, etc. So that operation essentially is obsolete. There was only a small cohort of gastric bypass within that group. Primarily these days, it's either the gastric bypass or the sleeve gastrectomy. Even the adjustable gastric banding has fallen to the wayside. And nowadays, unlike the old days in the SOS study and everything else, it's all done laparoscopically.
Right.
These are through small incision. Literally, the patient are being stayed in the hospital for a single night. So medicine has changed dramatically with regard to the surgical therapy.
And that leads me to the last question for a brief comment, is the sleeve versus the gastric bypass. I've seen some recent evidence that maybe later on after the procedure, the sleeve looks a little less adequate. What are your thoughts about that?
You know, there's actually multiple randomized trial between the sleeve and gastric bypass, and they're looking closer and closer. You know, but there are a couple of cohort of patients where they are separated. One, severe diabetes patient, and number two, patient with chronic gastroesophageal reflux. These are the two conditions where we believe that Roux-en-Y gastric bypass is a superior operation than the sleeve gastrectomy. I think you always have to do a fine balance act between the two operations, just because the Roux-en-Y, we essentially reroute the intestine, and there are consequences down the line for that. So yes, in one way, we want to achieve remission of disease, but we don't want to cause another issue down the line also. So it's a very fine balance. I present that to all my patients, and even some of the patient who has diabetes, once I kind of, show the difference between the two operations on the wrist, some of them even select the sleeve gastrectomy. They said, you know what? Although, yes, the remission rate is less, I understand that, but I'm willing to take that operation because it is a less risky operation down the line. Not necessarily immediately. They're both safe, but we're talking about 10 years down the line.
Okay, well, I want to thank the panelists for a vibrant discussion here about metabolic surgery and its impact on the care of patients with type 2 diabetes, and thank you all for participating.
Thank you.